thank you to Professor Miriam for joining us for today's session. Another batch this year, and it's a privilege and a great opportunity for all of us to hear from you directly during the session. So today we have Professor Miriam Johnson. She's a professor in palliative medicine. She is working at Hull York Medical School, and she's the director of Wolfson Palliative Care Research Center at University of Hull. And she's an adjunct professor at University of Technology, Sydney, Australia. And if you open any research publications on chronic breathlessness syndrome and palliative aspects of managing breathlessness, you will see Professor Miriam's name in most of these articles, and she has done a wonderful work in this field. And it is really a privilege for all of us to have her here in person talking to us about chronic breathlessness or respiratory symptom management. Thank you so much. Over to you, Miriam.
Thank you, and thank you again for the invitation. I'm just going to now see if I can successfully share my screen. So I'm hopeful that that is, can you see that in full slide view? Yes, that's a little message has said that yes, they can. That's good. So
we are seeing the presenter view. Is that okay? We are seeing the presenter view.
No, it shouldn't be actually.
Also. Yeah.
Yeah, no, it shouldn't be. Let me come out of stop share. I don't know why that should have been. Let's close that. Let me go. I think if I go on to slideshow, let me try again. If not, then, you'll just have a little preview and then you can be excited to see what's coming up next. I'm going to try again, share, and then let's go into slideshow from the beginning. Right. No, you're going to get the next.
Yeah, we can see the.
That's fine. There's absolutely no worries. Okay. If you get bored with the current slides, you can have a little sneak preview of the next one, and I'm absolutely fine about that. And you can check that I'm not shortchanging you by missing out any, because you'd have already seen what's coming. So palliation of respiratory symptoms, most of this, the vast majority, is going to be about breathlessness. So why is this important is very neglected. And then I'm going to talk to you about a clinical framework of managing and assessing, which is breathing, thinking functionally, which has been developed by the Cambridge Centre by Sarah Booth and Anna Spathis. And then I'm going to give you a couple of slides of the whistle stop tour of what you might be able to do about chronic cough. So, Invisible. This is a fascinating trial. It was done, it's an online randomized control trial. And this scenario was sent out to respiratory physicians in Sweden. And they were randomized because half of the scenarios were about somebody who had severe pain on follow-up and somebody who had severe breathlessness on follow-up. But the core is the same. So a 59-year-old person, severe COPD, former smoker, triple inhalation therapy, and had been vaccinated and had had individualized pulmonary rehabilitation. So by anybody's stretch of the imagination, they had had full optimized treatment for the COPD, and at follow-up, they either present with severe breathlessness or pain, depending which scenario the clinician got, markedly restricting daily activities and unchanged for 3 months. So this is not just a flash in the pan, it's just popped up yesterday, it might settle. They were taking paracetamol and they had a non-steroidal allergy. So the questions to the respiratory physicians was, does this person need further treatment? And 2, if so, what type of treatment? And this is the thing that, the sneak previews who saw what was coming next is so shocking. At least I find this shocking. So those randomized to the chronic pain arm, so down the red side, about 30% of them said, yes, this person needs further treatment. And most of them came up with some sort of symptomatic treatment, and most of that, it was an opioid. But with the chronic breathlessness arm, only 10% said that this patient needs more treatment. And very few wanted to come up with a symptomatic treatment, and an even smaller percentage came up with, well, we might consider an opioid. So, here is someone who's severely affected by a symptom that's markedly restricting their daily activities, and they've been stuck with it for at least 3 months. But yet the vast majority of these, I'm sure, perfectly reasonably very good physicians did not see this situation as something that was for them to worry about. Now, here's another interesting thing that might interest you. So my colleague, Sunita Daniel, conducted some focus groups with Indian clinicians working in Kerala. And we wanted to talk, we wanted to know what their views and experience was of, the recently coined chronic breathlessness syndrome, its recognition, its management. There are 3 focus groups with 15 physicians from a range of specialities. And they found that, yes, they recognized that persistent breathlessness was prevalent and had a major impact on patients, families, and their physicians. And they said it makes us feel really helpless. There was this sense that there was nothing that they could do. They could see it was really bad and awful for people, but they felt so useless in terms of being able to help the patients. And so what they found as well was that this kind of the way they dealt with this was by not seeing it. Poor awareness by the clinicians, accompanied by actively avoiding the subject. And one of the other things that came through was, well, if we had more access to palliative care, we might be able to think we could do something about it, perhaps. And all these things moved into contributing to this invisibility of chronic breathlessness as something which we need to deal with and address. So here's a sample quote. "Oh, we're very sensitive to a patient's pain, but we don't understand dyspnea. We all tend to underestimate the presence of breathlessness. It's very difficult for the bystanders who are also with them to cope with the stress. They recognize this is actually stressful when you allow yourself to see it. Well, these patients are already breathless patients, so actually we'll try and ignore them, whether the breathlessness is increasing or decreasing. And these aren't clinicians who don't like their patients. They really want to help. But it's a distressing situation to feel here's something awful that we can't do anything about." So this isn't a new thing. It's been noted since back in the 80s that this is actually often missed. But the reason why it's so important is that actually there are evidence-based interventions targeted at the breathlessness itself, which can help. So therefore, we really should measure and identify, assess in every patient. And it has to be active identification. If you wait until the breathlessness is now a physical sign, that's actually, people are really, really seriously unwell at that point. And most people, even if they're living with severe breathlessness, when they're sat down in the consultation at rest, they may not appear to be breathless in terms of a clinical sign. So we really do have to search for the symptom that patient experience and signal to them this is something which is legitimate to bring to the consultation, because there's this idea of, well, I'm bound to be breathless, I've got COPD, or I'm bound to be breathless, I've got whatever. And if we do not actively elicit it, it's likely not to be disclosed. So here's a basic, simple approach to breathlessness management that's quite old now. This was coined by Graham Rocker and his team in Canada in 2007, but the principles are still very pertinent. So number 1, optimize the treatment of the underlying disease. Then he has it as a second step. I would actually say, while you're doing that, let's try and use some non-pharmacological measures to help the person manage their breathlessness and refer them to, obviously some things you can't, because pulmonary rehab, you'll have to wait for a diagnosis, but things like encouraging physical activity, encouraging things like how you think and deal with anxious thoughts, simple interventions like the handheld fan, teaching them how to pace and prioritize physical activity, techniques to help with anxiety management, relaxation, pursed lip breathing, long out breath, diaphragm, all these things. These can be done alongside trying to figure out what's causing the breathlessness. Education and support for family carers is really, really important, because if they see their loved one struggling for breath, the temptation is they'll say, no, you sit there, I'll go and get whatever. And that person becomes more and more and more deconditioned. Also important to have a crisis plan in place, so that when that breathlessness has an episode where it's a lot worse, that the patient has strategies they can put in place to see if they can get back in control of it. And then only as a last step in all of this will we consider, for the most severely breathless, some low dose, sustained release, or at least steady state with repeated dosing, oral morphine. So that's a good structure to start with. Evidence-based, I said we have evidence bases for these things. Well, we have evidence base for complex interventions in this space. So you know about pulmonary rehabilitation. There's a very good evidence base. The effect size is as good as our fancy inhalers and drugs. Breathlessness intervention services are also developing now a good evidence base. So this is more so developed in people with more advanced disease coming from the palliative care sector. People typically who can't quite cope with the very aerobic component for the exercise and pulmonary rehabilitation. Note, however, breathlessness is a barrier to attendance and completion of pulmonary rehab. So shouldn't we be teaching people some techniques to manage their breathlessness, even as we refer them to pulmonary rehab, so that they don't think you're completely mad by sending someone who's really breathless to something which is going to make them feel even more breathless while they attend the rehabilitation classes. People with modified MRC class 3 and 4 breathlessness can have good improvements with pulmonary rehabilitation. So just because they're really severely breathless does not mean you shouldn't refer them to pulmonary rehab. However, I would say breathlessness management needs to be dealt with and addressed up front. If we just say, off you go, the patient will vote with their feet because you've just put them in a very frightening position of making their breathing worse with physical activity without giving them strategies how to deal with it. And I would also say, particularly to the doctors on the call, as a doctor myself, you know, the tendency is that we reach for the prescription pad. And although we kind of know that the physiotherapists do good stuff and we know that these things can happen, it's nothing to do with us. I would say it absolutely is to do with us. Firstly, we can learn some of these simple techniques to teach ourselves. But secondly, if we prescribe, in quotes, and strongly endorse these interventions, we will help support the people, the allied health professionals in our team, so that the patients take them seriously. The physiotherapist, occupational therapist, and nurse are crucial, but the doctor should also be familiar with and introduce these interventions to the patient. So, I want to change tack just for a little bit, because one of the key things to understanding how to manage these people who live with breathlessness every day, it's part of their experience and existence, is that if you put healthy volunteers into a functional MRI scan and you make them very, very breathless, you will get all the threat pathways in their brain lighting up. If you put a patient who is living with chronic breathlessness due to, for example, COPD in that functional MRI scanner, and you make them breathless, not only do the threat pathways light up, but all their frontal association cortices about fear and memory. And what we know and understand is that the brain creates expectations and beliefs based on previous experience. So if they have had really bad experience of frightening breathlessness in the past, their brain is already sensitized to those alerts coming in. And that really feeds in and amplifies some of the signals. And if we don't understand that and we don't deal with these issues about anticipation and fear and concern and worry and anxiety, we will miss the boat in terms of optimally treating these people. So I think I've just said that. That's some really nice work from the Oxford Functional MRI Centre. And interestingly enough, one of the studies they did was that they scanned the brains of people starting off pulmonary rehabilitation, and they repeated it at the end of rehabilitation. And they showed a corresponding reduction in frontal lobe cortical activity, as well as an improvement in their breathlessness. So pulmonary rehab is really, really important. And tackling expectations, fears, worries, is really important, understanding what that breathlessness means to people. And the other interesting thing coming out of that group is an interesting small piece of work suggesting that opioids actually can help suppress those conditioned anticipatory brain responses. Now, that hasn't been tested full and repeat dosing, but there's a little something there which is an interesting snippet of information for you. So moving on to the breathing, thinking, functioning cycle, as I say, You know, it's a sad day. Sarah Booth died before Christmas, but she's left this incredible legacy of this clinical pattern, which is being taken on and developed by Anna Spathis and the team in Cambridge. And it recognises that breathlessness experience is like a vicious cycle that can be wound up or wound down. And there are a number of corresponding cycles that feed into this, but the three main big ones seem to be the pattern of breathing. How efficiently do people breathe? Secondly, what's going on in cognition and our thinking? Oh, we've been talking about memories of past experience, conceptions, what does this mean? And then the functioning one, which you're probably very familiar with. If activity makes you breathless, and you know, the easiest thing is just, well, don't do that again, and you're not breathless. Amazing. But then what happens is the next time you do even a little tiny bit of activity, you're then breathless because you've become deconditioned and your muscles have become less and less good quality. And so it becomes a vicious cycle whereby people become breathless with less and less and less activity trigger. It also has the effect of making that people are socially isolated, more reliant on help, their role in the family and community and society is eroded, and it all just becomes this dreadful decreasing cycle. So let's have a think about what we might be able to do with the breathing. So, for example, you may be familiar with the concept of long out breath. Well, that helps reduce hyperdynamic inflation. So, you know, we explain to the patient, it's obvious, isn't it? Well, you can't cram more breath into lungs that are already filled with air. You need to get rid of some before you can put some back in. Pursed lip expiration, which of course also increases your positive end expiratory pressure. Rectangle breathing, which is asking the patient to visualize a rectangle and just to breathe out on the long side, in on the short side, or using numbers, you know, breathe out for 6, breathe in for 2, whatever works, trying to enable them to empty their lungs before they bring in another breath. This also helps reduce respiratory rate. It reduces dead space breathing, allows better chest wall and lung tissue movement. It's often incorporated into things like yoga or Tai Chi, which may be something that patients are doing already. And you can use it in conjunction with the handheld fan while they're getting cool air over their face. And I just referenced Marchetti there, who also showed that the fan helped with that reducing dynamic hyperinflation, using it in terms of as you do your breathing long out breath. So here's just some work that we did. Your take-home message from this is that we had about 10 patients who were living with MMRC4, so very severe breathlessness. We scanned their brains while we exercised them and during recovery. Now, half of the recovery was with cool airflow over their face, and the other was just room air. And you can just see that the brain responds differently as to whether they're recovering with cool airflow over their face as to not. And they said, oh, that feels nice, and their breathlessness got better quicker. So possible mechanisms for how cool facial airflow may help breathlessness, particularly in recovery, is a possible neurorespiratory gate. Are we blocking off the unpleasant sensation, allowing more pleasant sensation to come in, thereby taking away the distress and reducing your respiratory rate? The French group, Morleau, Panzini and co. described this as fooling the brain that we're breathing more than we are. So here's another bit of evidence to support airflow relieving chronic breathlessness. So this was one of my fellows when she was a PhD student. Just some simple exploratory meta-analyses showing, so those of you familiar with forest plots, showing the big black diamond is very clearly in favor of the airflow in these 3 different situations, whether it's a handheld fan at rest, whether it's airflow delivered as cylinder medical air, or whether it's delivered as cylinder medical air during constant load exercise in pulmonary rehabilitation. And here's a systematic review where they found 9 randomized controlled trials and a cohort study of 344 patients in total. The 6 randomized controlled trials which were powered to detect effectiveness reported a significant improvement. The 3 that showed no difference were not designed with sufficient power for efficacy. They were feasibility studies. So qualitative findings, when we've asked patients how they feel about the use of the fan, here are some quotes. Well, I used to use Ventolin. That's a SABA. That's a beta agonist inhaler. Used to use up to 30 times a day. I don't use it at all now. Well, the best thing was it worked. Now I've reduced cooking, resumed cooking. I've got a much quicker recovery than I used to. So from what people say and also quantitative data, there is evidence behind the use of cool facial airflow. So that's so much for the breathing, thinking and emotion. We need to understand the triggers, the context and meaning of breathlessness. There's some useful work done thinking about crisis plans. And it's often about getting back in control of what's happening. Anxiety, panic interventions, including relaxation, music, yoga, whatever works in your setting. There's a good evidence base for cognitive behavioral therapy. I would say that with cognitive behavioral therapy in the acute crisis, where panic and fear are often very marked, people may not be able to access, if you like, the cognitive bit of their brain, and putting in some interventions which help get a sense of safety. So focusing on the panic and anxiety interventions at that first initial state, and then starting to get some of the cognitive behavioral therapy interventions there. Functioning, including how well people cope with their breathlessness and how they seek help for their breathlessness. And, you know, you can think of people you've seen in your clinic. There are some people who naturally have really adaptive ways of managing and coping their breathlessness. They find ways to keep physically active. They find ways to maintain social contact. They've got a good sense of self-effectiveness and self-support. And they have been able to either modify or otherwise maintain their role in the family and society. And then there are other patients who they get in this situation and they just seem to stop dead. Life seems to stop for them. They stop doing anything. They stop seeing any people. They feel very helpless. They have to receive it. It's other people's responsibility to help, and their role gets eroded very quickly. So remember the carer in all of this, involve them in education about and practice with the interventions. And there's a key role for the clinician in this. And another one of my fellows, part of her PhD work, she did a beautiful qualitative synthesis and demonstrated very clearly that where the patient has a clinician who will seek out and address the breathlessness as a symptom as well of the disease management, this will help the breathless patient move towards adaptive ways of dealing with their breathlessness. So on to pharmacological interventions. And I would say this is to be considered only for the very small group of people who remain very severely breathless. This is not, you do not start reaching for the prescription pad. This is really for those where they are very severely breathless. So firstly, low dose morphine is the one with the evidence base most well developed, strongest evidence in respiratory disease. And here you have a 2015 systematic review of people in COPD showing benefit. If you extend to, oh yes, and just to say here that the steady state studies showed a bigger effect size than those with just one-off doses. And that's partly why we strongly recommend that there's at least a steady state. So if you're using an immediate release preparation, then at least give it regularly, not just leaving for a PRN dose. Or if you have access to a sustained release preparation, using that for a steady state. If you extend to studies of all causes and diagnosis of breathlessness, again, this is 2017, you've got a clear little black diamond in favor of opioids. However, since that, they were small studies. Since then, there has been a 2019 MOP trial published. This is 7 days oral low-dose morphine, and they demonstrated no benefit in the primary outcome of breathlessness now. However, there were some methodological issues that made it difficult to interpret. Due to slow recruitment, the eligibility criteria is expanded to include people with much less severe breathlessness. And in a way, this doesn't make sense because you wouldn't be considering opioids in this patient group already anyway, and it reduces the power to detect benefit in those in whom it would be used clinically. Also, there was no measure of physical activity, so it may have improved exercise tolerance, but we wouldn't have picked that up. And also immediate release morphine was available in both arms, and it was noted had increased use in the placebo arm. So hard to interpret the findings of this trial. Then in 2020, the Dutch group published a positive trial at 4 weeks of multi-site placebo-controlled sustained release morphine in COPD. Their primary outcome was the COPD assessment tool, so a quality of life measure. And they also did, although overall there was no difference in breathlessness outcome, in the group who had MMRC 3 and 4, so those with moderate to severe breathlessness, that is where you saw the signal of breathlessness improvement in the morphine group. And then very recently, just before Christmas, we published another study. This was the BEAMS trial. Now this again, we're back to 7 days only. So we only have the data on the 7 days. And again, we found no difference in the breathlessness measure, despite only being MMRC 3 and 4. And there was no difference in the average daily step count. And so the conclusion from this paper is that on these data from these findings, you could not conclude that sustained release morphine made any difference. So what do we do about that? That's, how do we interpret this? We've got some trials that say yes, we've got some trials that struggle to find the benefit. So the comments on the BEAM study that I would say is that the primary endpoint was 7 days. And so far, the only 28-day data, that is the Dutch trial, did show benefit. Also, in my heart failure trial, it was only a small number. There was a signal of benefit, again, at 28 days. And then if you go back to the very original 2003 paper, which started off this repeat dose evidence, is that if you look at the inclusion criteria, these patients were breathless at rest. So this is the really, really breathless population. And we also know from pooled data analysis we did in 2014 that actually the patient who is most likely to respond to opioids for breathlessness are those with the more severe breathlessness. And once we extend it to patients who are able to move around, because physical activity is interwoven with the experience of breathlessness, it all becomes really difficult to unpick. Third point, the BEAMS trial used average daily steps. And the thing is, it's a very blunt instrument. There was a very interesting accompanying editorial by Schwartzstein who said, well, if you take a flight of stairs, the number of steps stays the same, but there is a very different experience for the person who can go up the stairs all in one, or the patient who has to go up the stairs and recover every 2 steps. So if you did the daily steps, just the step count, you'd see no difference. But what about the difference of getting somebody up the stairs in one go, rather than taking ages to get there, and they had a lot of distress to do it? So that makes you think. So we did do a subgroup study in the BEAMS study, which we couldn't fit into this main trial. And this was looking at the activity levels that patients were able to do. So mean active calories on the left side of your screen and mean minutes of lightly active. So whether moving from sedentary to light activity. And if you look at the blue line in both of those graphs, they are the placebo. And if you can see, there is a definite signal whereby patients receiving morphine compared with placebo were able to do more minutes of light activity in the day, and they had more active calories spent during the day. So there's a signal there that you're actually increasing exercise tolerance in these patients. So on to safety. Is it safe to use morphine for patients? I mean, when I was a medical student all those years ago, I was taught the day you give somebody morphine with COPD or heart failure, you'll kill them. Now, of course, if you give them in a severe exacerbation, then you might do. But in the stable chronic status, there is no evidence that with careful monitoring and appropriate dosing, that we will put these patients at risk. The key is, we know the safety profile of morphine, and we know that you should prescribe it for the right patient with due care and monitoring. This is the same principle for prescribing beta blockers, ACE inhibitors, beta agonists, diabetic medication, digoxin, chemotherapy. Any of these, if we give these to the wrong patient in the wrong dose and we don't take care of them, we can kill them. And morphine is no different. However, under appropriate prescribing and monitoring, there doesn't seem to be any evidence of significant serious adverse events so far. So what dose would we use for if we were going to try it for someone with breathlessness? Well, a dose finding study titrating from 10 to 30 milligrams of sustained release morphine a day. Of those who improved, 60% did so with 10 milligrams a day, and over 90% had done so by 20 milligrams a day. There was a small percentage who got further improvement at 30 milligrams a day. We do not need much. We are talking really low doses. So much for morphine. Just going straight on now to other drugs that might be used for the relief of breathlessness. Firstly, the Cochrane database systematic review, there is no evidence for or against benzodiazepines in patients with advanced cancer and COPD, and nothing particularly at all in any other disease group, simply because the studies are small, they're not designed to help. The design is such that the quality of the findings are very difficult, so we just don't know. There is, however, a well-designed trial in cancer patients using buspirone that demonstrated no difference. So there's evidence of no benefit. And the same for sertraline in patients with a range of conditions. There is a trial that is currently just completed, awaiting analysis, a big European trial led by Irene Higginson in King's, using mirtazapine or placebo. So watch that space, that should report over the next few months. So to summarize chronic breathlessness, the breathing, thinking, functioning model is useful for assessing and managing breathlessness. There are evidence-based non-drug and drug interventions that can help modulate the perception of breathlessness. I would say be a little bit careful with immediate release opioids. The evidence is in chronic breathlessness with sustained release. I would just add an aside to that, there are some ongoing studies of transmucosal fentanyl delivery prior to exertion, but we need to await the safety data and the phase 3 effectiveness data from that. But that's another little watch this space. Cognitive approaches can modify the emotional response, and exercise and other ways to maximize function are really important. So just a very quick gallop through chronic cough. Now, what I'm not talking here about is that obviously you have the disease-specific treatments for cough. This is when you've done that and you're left with this persistent cough. So thought to be due to hypersensitivity of the vagal afferents caused by epithelial damage, the epithelial damage from disease, smoke pollution, gaseous non-acid reflux. No, it's not acid itself. It seems to be the gaseous bit around that. And so there is evidence that PPIs, proton pump inhibitors, are not helpful. No benefit over placebo. So how might we help? There is a useful guideline published by the European Respiratory Journal, if you're interested to see. And it also raises the issue that there are non-pharmacological treatments, so cough suppression therapies therapy by trained therapists, and some simple drugs that might help. So pro-motility agents would help keep the acid going in the right direction. So azithromycin once a day as a motilin agonist, metoclopramide or domperidone to increase the tone in the lower esophageal sphincter, and a very nice published paper by Alan Maurice, low-dose morphine, 10 milligrams twice daily, works in about a third of patients as recommended in the guidelines. Just a new thing published by the Lancet in 2022, epithelial damage also releases alarmins, which can act on the P2X3 receptor, and the P2X3 antagonist appears to be more effective than placebo. So again, something that might come on in the future. But I would point to the cheaper azithromycin option perhaps first. So thank you for your attention, and hand back over to Dr. Sridevi.
Thank you so much, Miriam. We'll wait for a few questions or comments from the participants. Either you can unmute yourself or You can type your questions in the chat.
I might ask a question, if I may, to get the ball rolling. I'd be really interested to hear people's experience of accessing the non-pharmacological interventions in their own clinical settings. Do you have physiotherapists, nurses? Do you use these techniques yourself for patients? Do they have access to them? I'd be really, really interested to hear. Well, I see there's a question come through. Any role of morphine in the acute exacerbation of COPD? I personally, I would think if they're already established on morphine, I guess you could maybe think of it. And my gut is that in the acute situation, morphine isn't where you want to go unless they are actively deteriorating and there is a lot of breathlessness distress, as somebody is in the last days and days of life. I would treat the exacerbation as you would normally and review, but you might like to then consider what is their usual baseline chronic breathlessness. Have they had access to non-pharmacological interventions, and try those first. I would say that I would go, and azithromycin I would use, the azithromycin would be in terms of cough rather than breathlessness. And that's chronic cough, as opposed to in an exacerbation of COPD where you have increased sputum to clear. So the acute exacerbations, I think, are particular separate issues that I would get the patient over the acute situation for clarity and use your standard interventions for that. But you can certainly use non-pharmacological breathlessness measures to help them control their breathlessness during their acute exacerbation of COPD. But I would probably not dive in with an opioid at that point, if that makes sense. Happy to come back on that and explain further if that's not clear.
Good evening. Which one you prefer in chronic cough, whether codeine or morphine? Even codeine is very difficult to procure in our setting.
Yeah, I would start with see if you can get access to some of the non-pharmacological cough suppressant treatment, and I would then trial sustained release morphine or regular up to start. I would say 10 milligrams a day in divided doses and go up to 20 milligrams a day in divided doses. If you're prescribing morphine for anything, please remember to co-prescribe a laxative. Even if the patient says they don't need it, at least make sure they've got it at home. Because if you then get them constipated, you're then going to restrict their diaphragmatic excursions and you may make their breathlessness worse. So make sure they don't get constipated. Just going back to the chat again, what percent of patients with chronic breathlessness benefit from fan therapy? Well, from the study I quoted, about 82% said they got at least some benefit. So I would say you've got to, and given that there's well, I'm sure they could have a harm from it if they tried very hard. If they shoved it too close to their face and took the end of their nose off. But I think they'd have to work really, really hard to get harm from it. Then, why not try it and see what they say? How long do we prescribe low dose morphine? I would say I would give them a week to see whether it helps or not. And what we tend to do is to say, right, well, what are we trying to improve? Because of this issue of you might miss a benefit if these patients are ambulant. So I'll say to the patient, right, what are you trying to do? Well, I'd really like to get to the bus stop at the end of my road. I can't at the moment because my breathlessness won't let me. So I'll put them on some morphine, see them in a week. Have you got to the bus stop? Yes, great. In that case, I'd carry on. If they hadn't got to the bus stop, I would then try dose escalating and ask them again in another week. And I'd go up to a maximum of 30 milligrams a day. And if they still hadn't got any benefit in terms of what we're looking for specifically, I would then say, well, we'll stop it. How long would I keep it if it helped? I think it depends on the patient. I mean, certainly if we find that this allows patient to then start becoming much more ambulant and we start to undo that functional breathlessness cycle, so they're moving better, their muscles are getting better, their breathing patterns are getting better, I would then try and, after a few months, I would say, right, well, let's see if we can wean the morphine down and stop it and see how you are. I think particularly with patients who maybe otherwise end up on morphine for many months or even years, we have to learn from the lessons from the chronic pain world, where we know there is a very bad legacy of endocrine suppression, potential issues with immune suppression, let alone addictions and difficulties with inappropriate use. So we've got to be really clear why you're giving it, what you're looking to improve, and then consider when you might stop it.
Any other questions? Yeah, there is another question.
Oh, hang on, there's modafinil with, right. With regard to the modafinil, I would say I have no experience of using that with respiratory failure patients. And I think with a lot of these things, one has to be quite careful and look at the evidence base, and some things I think we should keep to use in the context of a clinical trial. So I would have to say I would have to bow to other people's expertise and experience with that. And here is another question. Oh, it's a comment, that's nice. Well, someone saying that actually the anxiety worsened the breathlessness. Absolutely. A standing fan at the bedside helped ease the breathlessness. And that sounds like that was a trigger. So that sounds like a good story of an example of where some airflow really helped that getting back in control with the breathlessness. I think too, it also helps with just it's a good illustration of how people's experience with breathlessness isn't just one thing. It's not just the physical disease, but it is also the patient's emotional response to what's going on, and how fear and fright and panic and anxiety can just feed into that breathlessness cycle, particularly with there's a comment there, not retaining CO2. You can actually end up with people hyperventilating and becoming quite symptomatic. So thank you for that example. I mean, other people, I'd be really interested to hear other people's experience of using some of these non-pharmacological techniques. Question about dextromethorphan. I think what I would do is just point you to that European Respiratory Journal guidelines. It's included in that paper, and rather than get it wrong, I would point it to them. I know it's included, and off the top of my head, I can't give you exact chapter and verse. So that paper is really, really worth getting that out and having a good read. It's a really useful bringing together of all the literature.
I was wondering if there is any response to what you asked some time back. Do the patients have access to the non-pharmacological services? Do you?
And just pop it in the chat, you know, if you don't want to speak out, but I'd be really interested to know how you feel this might get incorporated into your own practice.
And I think there is a general tendency, or it's a practice, that when you are breathless or coughing, even for kids, we switch off all the fans, we close all the windows so that the air is not causing. It's said that it can cause more breathlessness or more of a cough. That's the general notion about fans. And
I mean, there is certainly a sweet spot, I would say, that too fast airflow. We've just completed a study with people living with quite significant breathlessness, testing different airflows from the fan. And once you start getting above like 3.5 meters per second, so we had some that went right up to 4 and above, and the patient said, oh no, don't like that. And it's like patients will tell you if they go out on a really, really windy day, they just say it takes my breath away. And the fan rates that are too high, you know, that makes their eyes water. So there is a sweet spot, but also too low. We can demonstrate in the studies that as you increase the rate, so the benefit increases too. But then there's a tipping point above which patients say, no, I don't like it. So absolutely. I always smile about the, you've got to turn off the heating, shut the windows. My granny, I think this is an international thing about grandmothers. oh, you know, you don't want to sit in a draft, you'll get pneumonia. Or dire things will happen to you if you sit in a draft. So I think there are some of these inbuilt, ingrained things that you might just have to gently listen to and gently rebut and say, well, no, actually, we know that if we use this particular type of airflow in this particular way, we know it can help the way that your brain responds to the breathlessness, and we can make it feel better. Why don't we try it? You know, the best way of trying it is to actually have the fan in the clinic and to gently let the patient try it while you're there. Often practicing, why I tend to get them practice the long out breath with the fan on, and then say, well, just feel that air being, you know, pushed into your face and down into your lungs as you take that next breath in. So they can see it, they can experience it while they're there. I think we know that if you just say, oh, go and buy a fan, firstly, they don't know what, we know that flow rate does matter. So the ones that kind of like you can't feel anywhere aren't any good, and neither do you want the ones that blow your head off. So advising them, you know, once they get to feel it themselves, otherwise, well, you know, why are they telling me to go and get a fan? That's what you give hot babies or hot grannies or, you know, menopausal women. There's a real credibility gap, and I think part of it is using, you know, is being that clinician for them and saying, no, actually, there is science behind this, and let's try it. Like, here's one, let's try it now, see what you think.
I think there are two more questions in the chat. One is a comment and one is a question.
Okay, so role of nebulized antibiotics in chronic cough. I don't know. I think that's probably not within my expertise, and your respiratory physicians are probably, well, you're more respiratory physicians. I mean, have a look at the evidence. Go back at that European Respiratory Journal clinical guidelines for chronic cough and see what it says about that. It may or may not mention it, in which case that would be fun. Why don't you email the authors and say, what about? That's always fun, isn't it, to a bit of correspondence with people. Someone says, oh, good, you've got a pulmonary rehabilitation respiratory physiotherapist, also teach basic PLB, pulmonary lung breathing. Pursed lip breathing, thank you. And relaxing, that's brilliant. So there's someone there already implementing these techniques into their practice. Next one, tackling the thinking limb definitely helps. We've clinically noticed it, absolutely. So that's great, someone else implementing that. Small hospital in rural North India, pulmonary rehab with physio, OT, aerobic exercise. Breathers is fantastic, positional variations, brilliant. Isn't that lovely to see that some of these things starting to be implemented? That's absolutely fabulous.
So I have a question. So we know that there is a strong evidence for supporting the use of fan for chronic breathlessness. But in your clinical experience, how could you put that into practice? I mean, not to patients, even in your clinical team, to convince people, okay, try this fan before you start morphine. Like, how could you actually convince your team to start this practice? Yeah. That's where.
Well, firstly, I would say to your clinical team, morphine for people is for people who are breathless at rest. If they're not breathless at rest, don't think about it. The evidence isn't there yet. Well, I mean, okay, I can buy MMRC4, so people who are breathless getting dressed, they struggle to get out of the house. It really does impede their physical mobility. Now, that's not to say that with the subsequent data coming out, building on our exploratory work, won't say actually it does improve physical exercise tolerance and that we should use it for a little bit of time to help them rehabilitate. So that story might change, but at the minute, it's very hard to say, we will give routinely people who are otherwise, out and about, they might be a bit restricted, but they're not terribly restricted, morphine. So that's my first thing is to say, really think carefully before you consider morphine for breathlessness. In terms of the non-pharmacological, I would get, in our teaching, we get people to experience breathlessness. I know it sounds bad. We get little straws and we get them to breathe through the straw with their nose held. We get them to get up and down and up and down and up and down in the chair, get them to feel what it's like, and then we give them the fan. And so, just practice that breathing with that. And we do it with, and we do it with that, and they experience it themselves. as part of our training and teaching, because I think many of us in clinical care, we learn by doing, don't we? It's all very well having the head knowledge, and we like to think we're very, very evidence-based, but sometimes we need to experience it. And then and now go and try it with some of your patients and listen to what they tell you. For example, in my clinic, things you can incorporate really easily in clinic, like teaching them how to do sit to stands. You know, so I do a very quick, and at the end, I say, right now, we've talked about this. What I want to do is send you out with some very quick top tips of things you can try yourself that I want you to try now. First of all, here is a fan. Now I want you to sit comfortably forward in your chair. So I get them into a recovery position. Now hold the fan here. Now let's turn it on. Okay, now you see that whizzing around. You feel that on your face. I want you to breathe out as long as you can into the fan and then let it push the air back into your lungs. So I'm doing positioning, I'm doing fan, I'm doing long out breath. And then as I said, let's practice that again. Now, okay, now when you're breathless, how do you feel? Do you feel scared? Do you feel comfortable? Do you feel worried? Okay, it's often frightening, isn't it? So let's practice some techniques. Let's do some relaxing of the shoulders. That's it, bring your shoulders down. And then I say, now, just before I let you go, I'm going to get you to do one more thing. And I'll get you to do sit to stand in the chair. And I say, I want you to do that several times a day. If you're watching the television and there's some adverts come on, I want you to do some sit to stands while the adverts are on, and then you can sit back down again. And it is transformative. You know, I've had people who come in who really struggle to get out of the chair. And the next month they come back in. I remember one lady, she came marching in, she said, before you say anything, and she sat down in the chair and she went, look at this. And she said, I'm back to the shops. This was top tips. And nobody had, she said, why has nobody taught me how to do these things before? She said, I've been coming to doctors, and they don't ask me about it and they don't tell me anything. Why has nobody? She said, that took you 10, 15 minutes to teach me that in the last clinic. And I wouldn't blame patients for feeling angry that nobody has told them about this, because the only thing we reach for as doctors is the prescription pad. When the evidence is there. So right, I feel so much better. Thank you for letting me have a little rant and on my high horse. But it is, you know, such a common thing when people have come to my clinic and they say, why has nobody told me about this before? Before I carry on ranting, I better someone else has popped something here. Again, I'm going to pass on that question of which particular vaccine you need for pneumococcus. That's part of your standard treatment for your COPD or people, and I would defer to whatever the current guideline is with that. But good that you're thinking about it, because it's all part of that standard treatment.
Is there any guidelines or any document that you hand over to patients, like simple exercises like sit and stand, how to use the fan, the positioning? Is there any handouts that you give to the patients? Like,
well, yes, and there are two things. And what I'll do is I will send to Rajlakshmi a couple of links of some resources that you can use that we're very happy for you to use. Please adapt to your own situation. You'll know which bits are complete nonsense for your own setting and which you might need to tweak and which bits you can pick and choose. So we have an information booklet called Living Well with Breathlessness, which has things like the handheld fan. It's got positions, it's got some thoughts to challenge and some patient experience stories so they don't feel quite so alone. I'm happy to send that. And also the Cambridge Breathlessness Intervention Service have got some nice online resources that you can print off. So for example, for the fan, for various bits and pieces, they've also got a nice little animated video which explains why we might feel breathless and why the fan might help, for example. So there are some resources out there and I will happily pass those on, and they're free to use. The other resource place, which is really, if you've never found it before, if you look at the International Respiratory, now hang on, the International Primary Care Respiratory Group, the IPCRG, again, I'll send you this link. They have got some fantastic resources about breathlessness that are free to use and download and use. So I will send those 3 resources through for you to send around to people who are interested.
Yeah, that would be great, because as you said, we know that there is evidence, but many a times things are not in practice. even many of our settings, and
Yeah.
our work mostly based in the community setting. So these kind of pharmacological techniques works really well, but we have to
one thing,
and the patients and the family, how beneficial it is.
One of the things that actually may be of interest to people as well is that we are in the process of doing a research study in conjunction with Naveen Salines and our very own Rajam and Rajni Bhatt and a few others about developing a short intervention that could be implemented anywhere, but particularly community-based. And so, you know, this is where I'm really, really interested. If anyone wants to drop me a note by email about your own experience of what is possible to implement in your settings, roughly where you are, I'll be really, really interested to hear just your thoughts about that and to watch this space. You know, there will be something that we will hopefully come up with at the end of the study, which might be of interest to you.
Yeah, that would be great. I think there is one more question in the chat.
So again, management of refractory cough in IPF, I think it's the triazithromycin first. Well, it's the non-pharmacological cough suppressants. So things like dry swallow, wet swallow, so that they are there. And again, if you go to that European Respiratory Journal article, you will find those delineated in those guidelines. But I would say the first step would be, well, actually, I would think it'd be low dose, long acting morphine with laxative, and if that's not working, then go try azithromycin. You know, both of those are fairly cheap options, and hopefully would be reasonably accessible wherever you are.
Are there any other questions? Today we are not taking up any case presentation. So if you have any question before winding up, please you can spend a few more minutes. I'll wait for your sharing your resources. I think, yeah, there is one question from Dr. Gayatri.
Yes, absolutely, and nice to hear you. Yes, it's there are and all the other standard techniques in terms of cough assist, in terms of sputum clearance, of course, yes, and the chronic cough situation is kind of like, you know, those have all been done. So please carry on with all your standard cough approaches. So yes.
There are no more questions. I think we can wind up a little early today. Today we are not taking any case presentation because we wanted more discussion to happen, so we kept that slot open. So thank you so much, Miriam, for once again.
Thank you. And again, I'd love to hear your feedback and any comments that you have about your own experience. And actually, if you have anything you think, oh, actually, I'm going to try that now, you know, I'd be really interested in hearing either through the Dr. Sridevi's team, or you can ping me an email yourself if you like. But thank you.
Thank you so much. Thank you so much, all the participants. Kindly give your feedback before leaving today's session. See you next week with another interesting topic.